see it? Yes. Right? So I position in a way that they can angle and see their back. So the idea, if you think, right, it's inherently less precise because the cortical, the somatosensory homunculus, there's just limited representation of it. So then, for instance, with the guy that was so hypertonic, when he would go to move, he was so rigid that he wouldn't allow himself to move freely. So I was literally like, dude, just like try to relax your muscles. And what I might just say is, what I want you to do, these are my go-tos, I'll say, hey, or they might say, I've got pain with side bending, right? So then you have them, I don't get out of the way, but you have them set up so that they can visualize their back. That's the key, they just need to see it. If you remember in the literature, it shows that even just the visualization of their back facilitates down regulation. You're more aware, sensory-wise, of the area that's in pain than an area that you hardly ever look at, right? So I'd say, hey Dilbert, I want you to try to touch your toes. For today, we'll just say 5 times. Just go down, nice and relaxed. Don't think about tightening this or doing that. Don't think about anything else. But here's the key. Dilbert, when you do this, you need to be looking at the mirror. So what I might say is, go to the point where you can still see your back. So obviously you might pass an area where you're getting too far, where you just can't pick your head up, right? So I'd say, all right, Dilbert, go ahead and bend forward. Make sure you can see your back, and then come back up. Okay? And again, do that 5 times. And what they might be like, oh, but it kind of hurts. Well, I say, all right, well, maybe just don't go to the pain. Or, hey, remember that even though if it might just hurt, it's okay, right? Because it's safe. Then I might say, all right, Dilbert, do some side, that side bend left was painful, side bend to the left as far as you can. What I might do too is, as long as I'm out of the way of the reflection, I might say, all right, try it again. Just so that they can see it, I might say, hey, can you go a little further? And now, I'm helping them, right? So I'm guiding the movement. I'm not necessarily over-pressuring them, but I'm guiding them. So it becomes a little bit less threatening because they know I'm here for them and here to help them, right? I might say, hey, side bend left. I might say, hey, you know what? Try some squats. Keep watching your back, though. Do some squats. Just don't worry about form. Just drop your butt to the ground, see how you do. I might say, do that. How about marching in place? Right?
That's weird. I've never seen my back.
It's
so strange.
Right? And it really is. I mean, it is. It's crazy because you never look at it. So think of an area that you never look at. Your body's going to naturally want to protect it because it's not exactly sure where it is, what it's like, what it looks like. Right? So I would argue that every morning when you get out of bed before you get dressed, look at yourself in the back. Look at yourself. Check it out. Feel it. Right? So that's easy application for spine, right? It's really easy. You just need 2 mirrors. Even if they're 2 rolling mirrors, you just have to set them up. I might say, hey, Delbert, turn your head to the left, right? You got neck pain. You got pain with left rotation. Now this is where it gets tricky, so maybe go to the right so you can actually see it. So I might say, hey, you just keep watching the reflection and watch yourself. And then I might have to reposition it depending on which direction. Okay?
Do you try to alter their quality of movement at all?
If, for instance, with the guy who was like super rigid and stiff, I try to alter it. I'm not necessarily focusing on mechanics. I am trying to improve quality of movement, but especially if they're guarded or limited, then I might try sort of. But more often than not, it's just, hey, just allow yourself to move and actually just see what's happening normally. Because you're trying to establish that homeostasis. I'm not trying to give too many inputs that might alter or change the perception. Super easy application, right? The only thing is it's a little more intimate, so you might need a treatment room or in a day in the clinic when it's not as busy, you set up the mirrors, okay? You put your shirt back on. So another thing here, right? With the mirror,
So for females, you'll have them gown up so that they can actually see the skin?
I'll tell them to wear a sports bra.
Okay.
The key with this thing, as Delbert said, I've never seen my back before. So if you do it with clothes on, you're still not seeing your back. When you do things with extremities, so let's say, for instance, with extremities, you guys will see it better if you're over here. Come here. So let's say, what's your name?
Dustin.
Dustin?
Yeah. Nice to meet you.
So let's say Dustin has a painful arc, take your shirt off. I might not necessarily have them take their shirt off if I'm doing extremities, but what I will say is, and this is going to be troublesome, but I'll remove jewelry. He's got tattoos. I will cover him up. Even if I'm just using tape, like kinesio tape that's same color, I'll cover it up. But in this instance, you're coming over here. In this instance, this might not work or be as effective. Because, how long have you had this?
Not very.
That doesn't help. Let's say he had this for 3 years. Let's say he had this for 3 years, right? The neural signature of his arm and the cortical representation has a tattoo as well, at least for the last 3 years, right? So if you're doing extremities, you need to remove, for instance, if they're married or jewelry, you have to remove that because their left hand and their right hand, left hand's always used to having the watch, but the right isn't. So if you do it with the jewelry on, it's going to alter their perception of what's going on. So I might say, hey, Dustin, step forward. I'll demo what you're going to do. But hey, you've got pain when you raise your shoulder, right? Kind of like here. So what you're going to do is you're going to kind of angle yourself like this. Now you're just watching the reflection in the mirror. With extremities, you want to do uninvolved side first and then involved side. With spine, it's just about the visualization. So he's got a painful arc in his left shoulder, or shoulder pain, so I'd say, hey, Dustin, this is what you're going to do. You're just going to stand here. You're going to watch your reflection. You're just going to raise your arm up. Up and down. Maybe do that 5 times for today. I'd typically have people do 10, maybe up to 15. Maybe do like some, like you're kind of hugging someone or high-fiving. Maybe do like a little row action or like you're pushing and punching somebody. So try that 5 times on here. And usually they're like, well, that's kind of weird, or that's not too bad. What do you think?
It's kind of weird.
Yeah. It's going to be more weird if he didn't have tattoos. Because for the last couple months, he's establishing that neural connection that arm should have a tattoo. Now, so I said, all right, you did 5, 10, 15. Now, Dustin, now I want you to do both sides at the same time. So you kind of have to cradle. That's the thing. You have to get really close to these mirrors. But now you do both at the same time. And then that's when they're
That's
like,
even more tricky.
yeah. That's when people start to really freak out. They have this weird experience, but then they're like, they get it. They're like, oh wow, this makes sense. Especially because then they're like, oh well, what you'll see, so you guys can see. This is what happens with patients. They might say, hey, it hurts to lift to here, or that's all the range of motion that I have. And what will happen is that they do this. And when you assess them before, they were getting to here, right? But you do this, and then you're having them do both at the same time. And it might just be the distraction of the mirror itself, but then they start doing this. And they're like, oh, it feels like it's going the same. Or they might be doing this, but they're like, it feels like it's going the same. And you're like, oh, well, you know, it's okay. Just keep working on it. And then next thing you know, they're doing this. And then I might say, all right, now look over. And they go, oh my God, how cool is that, right? So that's easy application for upper extremity, right? So let me show you guys what I do. Julie, where'd you put the mirror?
You know, it's in the front over here. Here.
Oh, here it is. So that's, yeah, just for a quick demo. I know everyone wants to leave, but I'll show this and then one more thing. So I already broke a mirror in clinic, so I can't break this one. I'm dead serious. So, Hannah, do me a favor. Hannah, do me a favor.
Yeah.
Sit here. So let's say Hannah has pain in her left foot. Maybe she fractured and she was immobilized. So it's pretty, you're thinking, well, that's pretty nociceptive, right? She had a fracture. It's very consistent, normal ag and easing factors. Oops. Sorry. So I might say, all right, Hannah, so, sorry, I keep saying opposite. It's her right foot. Right foot that fractured, right foot that hurts. So I might say, Hannah, all right, this is what you're going to do. You're going to look at the reflection, okay? Just focus on the reflection. Now, the caveat is that before I do this, I tell them about the body's brain maps, and I tell them about sensitization. Kind of how I told you guys, just a slight little variation of the story I told you guys, but it incorporates the body's brain maps. I might say, hey, Hannah, do me a favor. Close your eyes. Lift up your left hand. How'd you know that was your left hand?
Just because.
Just because, right?
I learned that.
Okay, now close your eyes. Touch your left index finger to your nose. How'd you do that if your eyes are closed? How'd you know that that's where your nose was? And then it's like, well, I don't know, because I just know. Well, no, you know, because there's an area in the brain associated with the visual representation of who you are and where you are in space, proprioception. So Hannah, your right foot hurts, right, when you move it. So now, Hannah, so now just move your ankle up and down, and you watch here. Keep watching. It's kind of weird,
Yeah.
right? So now, Hannah, you might do inversion, eversion, right? Now do both at the same time. Then if you really want to trip people out, have one do like inversion, the other do eversion, and then they're like, oh. It's crazy, right?
Yeah.
So then, here's the thing too. So like for my lady, she has pain to pressure or palpation, right? So then I might do something like this, or I might say, all right, Hannah, let me borrow your foot. And I can do this at extremities as well. I might say, hey, how does that feel? And you say, that feels fine. That's not my foot that hurts. Watch here.
Okay.
Is that weird?
Yeah.
Does it feel like I'm touching on the other side?
No.
Not so much, but it's just
Not
weird,
so much,
right?
but it's just weird.
So then what I'll do is, as I'm doing that, this is what I was doing today actually, I was doing it like this. I was really just cranking on her heel. And then I might say, all right, now hang on, I'm gonna do both. Let me borrow your other foot. And then I just start doing both. Now what you guys don't see, that she might feel, is the pressure, keep watching the mirror, don't leave. Does the pressure feel the same on both sides? Feels a little different?
Yeah.
So sometimes I'll even get a little tricky, and I'll apply really deep pressure on this side and lighter pressure on this side, but the visual feedback makes it feel like it's the deep pressure to desensitize the other side. And I'll gradually load up the pressure. And then I'll do it the same on both sides. Right?
Yeah. It's really weird.
And so that visual feedback is so important. And if you guys saw, right, like I said, active range of motion, that's painful. Full passive range of motion, but not active range of motion. Sensitized states, right? Obviously with the CRPS, phantom limb pain, post-stroke. But even just some of these day-to-day things, right? You're thinking, oh, that's pretty nociceptive, right? She broke her ankle and it hurts when she puts pressure on it. That's like normal. Don't really have to do anything nervous system-wise. Why not? You can have this impact. And like I've had people that, oh, I had a flare-up, and now it's just like it hurts when I move it all the time. All right, well, let's pop out the mirror, do that for 2 minutes, now do both sides. And once again, it's like a reset. It makes it feel better. You're limited on your creativity, because then it's like, oh, well, Hannah's like, well, it doesn't hurt when you press on it, it hurts when I step on it. Well, then I'm like, okay, Hannah, and I keep saying, Hannah, can you move that out of the way? Stay there. Well, then I'm gonna say, all right, so now this is what we're gonna do. So she's a little bit taller, so I might even flip that on its side and use that, but I'll say, all right, so now I just want you to look here. What I want you to do is I want you to start pressing the weight on your left foot. So imagine there's a bug underneath your heel. Now just start pressing on it really hard, right? And so you're retraining weight bearing, right? So she's just mashing her heel, watching the reflection. And then I might say, all right, now do both sides. And you start doing both sides. Or I might even have people in standing and really just like toe touch over here, but full weight bear here, and have them do stuff like this. And then shift it over. So you just have to get creative, right? Okay, so then last thing, 2 things real quick. For the 2-point discrimination, I just use these. Real simple. When you're doing it, just light dimple of the skin. And you might say, you'll just do a demo, right? Like I'm gonna do it here. Nobody, does anybody have back pain? Where do you hurt? Take your shirt off. Turn around for me. I'll demo to them. Where do you hurt? Okay. I'll demo to them. This is what I'm gonna do. 2 versus 1 point, right? So I'm gonna touch you and you're gonna say, hey, can you tell that's 2? That's 1, right? So that's how you start. So then, normative ranges for the spine are anywhere, I think it's 55 plus or minus like 10. So let's start here. And I'll go and I'll say, hey, Dustin, tell me, oh, damn, there's a mirror. Do it this way. But I might say, maybe that way, so they can see. I might say, hey, 2 versus 1, are you ready? Good to go, have them close their eyes as well. Correct? 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 Demo. I'll go to the side of pain. Are you ready? You said right around here? A little higher. Right where Texas is? Sure. But you don't know it because you've never seen your back.
Not around Brownsville, huh?
Yeah, right around Brownsville. Yeah. All right, so you ready? Correct?
1,
Correct?
2,
Incorrect?
1,
Correct?
1,
Incorrect?
1,
Correct?
2,
Correct. So a little bit less accurate, and that's actually 65, so that's more outside the normative ranges. Let's try maybe something closer to normative ranges, right? The key with this is that while you're doing it, they need to get that auditory feedback if they're correct or incorrect to validate what they're feeling. Even if they're incorrect, they're at least feeling it, and so it could help, right? So you ready? So this is closer to normative ranges, still outside though.
2,
Correct?
1,
Correct?
1,
Correct?
2,
Incorrect?
2,
Incorrect?
2. I'm guessing.
Good guess. Correct?
1,
Correct?
2,
Correct?
2,
Correct?
1,
Correct?
1,
Correct?
2.
Incorrect. So maybe 70% accurate, right? And that was a lot closer to the normative values, just still a little bit outside. So I would say, hey, he's got sensory discrimination impaired. A little bit different when you're central to compare, like if it was left-sided low back pain or thoracic pain, well, you compare to the opposite side. But in the pamphlet that you guys have, you have the normative values to reference and say, hey, okay, yeah, that's not normal. So hey, I would say instead of trying to find wherever your rib went, it's lost, I would say maybe do some sensory discrimination. Maybe you realize that you have a tattoo back here, visualize it, and I would say that I would argue that that might help more than maybe anything else he's tried, right? Last but not least, it's 401. Let me show you guys one more thing. Whenever you finally educate people on the nervous system, Maggie, whenever you guys educate people on the nervous system, the more visual feedback they get, the better. So especially if you're going to do any type of neurodynamic treatment, any visual feedback will help. So that guy that came in, that pulled up that graphic, you saw the body chart. His pain was literally right here. So we're thinking it could be nociceptive. We're thinking it could be peripheral neurogenic because it could be dermatome, myotone associated. Either way, I'm going to probably treat it a little bit the same. Now, if I was thinking red flags, then I would refer out. If it was more of the central compromise, right? True neural compromise. So I went through a thorough exam with this guy. Long story short, he was very active for 6 months. And he was doing high interval training for 5 days a week. Now, 6 months, it wasn't until a month, after 6 months that he started having some pain. So and you're thinking, okay, well, if you all of a sudden start running, jumping, and doing all those things, what are you guys thinking? I hear it. Stress fracture. Right? I think I heard it, right? Fracture, stress fracture, sprain, strain, repetitive overuse. His pain was right here, right? So he sees person A, and person A tells him, hey, I don't know what it is, so go to person B. Person B says, hey, I think it's a stress fracture, so let's put you in a boot, just because that's protocol, we won't image you. He's a little more conservative, I like that. If it sounds like it tastes like it, and it looks like it, treat it as is, don't overutilize unnecessary healthcare, right? So he then gets in the boot. Within a few weeks of just starting to now walk again, pain persists. All right, this is weird. So now let's definitively do bone scans, MRIs to rule out stress fracture, stress reaction, or anything else scary. Gets those done, insignificant, other than some mild increase of inflammation on the inner side of the foot. So then he goes from a boot to a scooter to non-weight bearing for 5 weeks, transitions into a boot for another 4 weeks, and he's a smart dude. I ask him all the red flag, yellow flag questions, not many there other than just failed treatments and not knowing what's going on. So he comes in on Monday, and he's on a cane. He's done graded exposure to himself. He said, well, the doctor didn't really give me instruction as to how to wean off of this boot or this scooter, which is very common. You guys are going to be the ones to educate them. So he comes in and he says, well, yeah, I've gone from the scooter to the boot, and what I did at work is I started going a little bit here, a little bit there. He did graded exposure to get to walking without the boot. And he comes in and he looks level-headed, he's pretty clear. And I do the whole exam, functional movements. I had him doing squats, lunges, I had him do everything. I check his strength, he's strong. His flexibility is normal. The only thing, and at this point I'm like, damn it, like, am I gonna find something other than I know that I can educate him on? The neurodynamic testing was positive. And so I was like, hey, let me go grab something to show you so this makes more sense. And so I've got these in the clinic. I have lumbar and I've got cervical ones, and I hope this is a lumbar one, because if not, it's gonna be too tight. But I come up and I sit next to him, because I'm like, hey, Mr. Jones, like, really, is there any muscle that's connected from your heel cord all the way to your head that's gonna alter what you feel? No. And so I'll sit there and I'll be like, hey, look, check this out. I said, when I put you in that position, I extended your leg. First I did regular, I flexed him over, extended the leg, brought his ankle up. Do you see what's going on here, right? I already had educated him on how and why we experience pain and how the nerves are interconnected, because he said, you know, the pain started here and then it started to spread. And at first it was like this bone pain, which you're thinking, well, that makes sense based on what he was telling you, but now it's just like weird stiffness and tightness. I don't know what's going on. All right, let me try this. So then the idea behind preloading that I was telling you guys is that if you do it, I did regular straight leg raise on him, and I did a posterior tib bias straight leg raise test, and it wasn't enough to wind up the system to get a positive. So then what I did was I dorsiflexed and inverted his foot. I had him sit straight, so I dorsiflexed, inverted, I extended, and then I had him slouch his back, and I had him lean forward. And that was the trigger that was able to elicit his symptoms. But I had to preload it from where I felt the site of compromise was to actually elicit that positive. Now, when I did that for two reasons. I did it, one, to show him that I have a pretty good idea of what I think is going on, because he felt like nobody knew. And it was really cool because when I explained it to him, he started to cry. He's 28 years old, he's a guy, and very physically fit and active. He just wants to be able to walk. His goals are, I want to be able first to walk without a cane, and then be able to run again. And I felt like I did enough of educating to provide that hope and show him, hey, I'm pretty savvy about pain. I think I know what's going on. But more importantly, when you then identify that this could be a potential treatment, you're able to show them, look, this is what we're doing, right? You're doing neural glides. And granted, it might not be as taught, but you're taking it through the system, or you're winding it up at different interfaces. And that was his homework. He's going to do neural glides, for him, biased towards the posterior tibial nerve, right? But this stuff is really cool when people are having like weird symptoms, for instance, like along the median nerve. You might say, hey, look, right? This is your nerve, this is how it comes out. It makes sense that, hey, if you're carrying a tray, or the ulnar nerve, if you're carrying a tray for a long period of time, you're putting constant load and pressure on that nerve, so it's going to increase the sensitivity of it. So then you might say, all right, well, look, you want to know why I take your arm through these funky movements? You know, this is why. And so you're able to show them that what you're doing is mobilizing the nervous system, which you've already told them makes up, is over 400 nerves of the body that requires 20% of the oxygen, right? So you're saying you're doing targeted movements in a non-threatening way, right? You're not doing tensioners. Old school of thought would be that you do this and you hold this for minutes at a time. When now we know that if you do that, you're decreasing oxygen. If you stretch your nerve by more than 15%, you cut off all blood supply. And if you stretch it by more than 8%, you decrease blood supply. So the idea is to do more sliding movements. And you're able to show them that this is the treatment that I'm going to do for you, and this is the treatment that I'm going to have you do on your own. And they're like, okay, I get it, that makes sense. And so it's more about the why, and the more visual you are, the better, because then they're able to understand it. And so that was what I thought was going to be an hour in like 15, 20 minutes. But any questions on all that? Because probably it's Friday, I want to go. Yeah.
Good job.
So yeah, demonstrate, educate, and provide hope, really. Careful what you say, because that shit sticks. And I've cussed a few times, I'm sorry. But we talked about it yesterday in a meeting. Carly, my colleague, was like, how fired up did you get? And I was like, yeah, I got pretty fired up. I probably cussed a few times. But it's with reason when you think about it, right? So if you guys have any questions, when you guys are on rotation and you guys are scratching your head, feel free to shoot me an email. I'm there to help out. And yeah, hopefully hopefully you guys learned something.
You're not.